So now something quickly on lateral unis, something I'm very keen on doing, something that's not very often done. If you look at the indications for a lateral uni, I think they're pretty much the same as for a medial uni. There need to be lateral end stage osteoarthritis, bone on bone. Sometimes you can find that on the Rosenberg view with normal regular AP views, as I showed you previously. The ACL has to be functionally intact. Deformity, the interarticular part of the deformity needs to be correctable, as with the medial uni. You can ignore the patellofemoral joint unless there's bone on bone or it's clearly symptomatic, as we talked about previously. And there's a special separate indication for a lateral uni, that is to add a well-functioning, to add a lateral uni to a well-functioning medial uni where there is lateral end stage OA. So what do you need? Basically the same as with the medial uni. You need a stress X-ray to see if the deformity is correctable, if you have any doubts about that, or if you have any doubts about the lateral collateral ligament status. You need 3-foot standing films if you're worried about the amount of valgus, or if you just want to analyze the deformity to know if there's room for an osteotomy. And you need a Rosenberg view to get a good view of the posterolateral part of the tibia plateau. You need to keep in mind when doing the surgery that the lateral side differs very much from the medial side, that there is a rollback mechanism and a screw home mechanism that comes into play on the lateral side compared to the more ball and socket type articulation on the medial side of the knee. You also need to keep in mind that there's increased laxity on the lateral side, so the normal rules of ligament balancing don't apply to the lateral side. And it's very important that you aim for a slight undercorrection of the deformity. You need to leave the knee in valgus. The lateral unis are much more sensible to the final alignment than with a medial uni. Medial unis, as I showed you, are sensitive to that as well, but not as sensitive as with a lateral uni. So something on surgical technique. You need to do a lateral parapatellar arthrotomy, but then the patellar tendon and the patella are in the way. What I do, as you can see in this circle, I resect part of the lateral patellar facet that allows easier access to the femur. And to do the sagittal cut, I actually go through the patella to get that reciprocal saw in the correct position. Because if you try to work around the patellar tendon, often you end up malrotating the tibia plateau, because the patellar tendon forces you into an incorrect rotational position. An easy trick to get to know the center of the tibial component is to draw a line in the central part of the lateral femoral condyle with your electrocautery, and then extend the leg, and then where that electrocautery line on the femoral condyle hits the tibia plateau, that's where the center of your tibia plateau needs to be. But it's another way of avoiding rotational errors and avoiding errors in the medial lateral position of the tibia component. So with the tibia component, you need to be wary of the patella tendon and the rotational position of the tibia component. With the femur, you need to be wary of the rotational position as well, and that's because of the screw home mechanism. The tibia externally rotates on the femur during extension. And if you've got a too central femoral component position, as you can see in the top left picture, if you then extend the leg, the femoral component will actually hit will cause impingement. So a very easy trick to avoid that is to have the femoral component follow the lateral femoral condyle border. So the chamfer cutting block, you'll need to seat that right on the edge of the femoral condyle. If you do that, you avoid that impingement problem. So to round it off, two lateral uni cases, you know, just to give you an idea that you can expand your indications for doing unis. This is a lady that's 75-year-old. When she came in, she had this patellofemoral joint that was in there for 15 years. It was well functioning. Wasn't completely happy with the axial or the patella skyline view. I mean, with the positioning of the patella component, but she'd been doing for 15 years with that patella component position. So I, decided to ignore that. Her pain was strictly lateral. Medial compartment was intact on the stress X-ray. As you can see in the bottom, the second picture from the left is the stress X-ray, which actually shows you that the deformity is correctable and the medial compartment stays intact on varus stress. And her leg alignment was in quite a bit of valgus. So I was happy with her to add in a lateral uni. And she, for now, she's happy with that. Second case, this is what I discussed about. That's that separate group of that separate indication for doing a lateral uni. A 64-year-old male that had this medial mobile bearing implant implanted 18 years ago. And he was still happy, very happy with that. And he said, well, my medial pain is gone. It's still gone. I'm still happy with the implant, but I have lateral pain now. So can you do something about that? His ACL was functionally intact. You can't judge the tibia plateau anymore because it's gone. It's replaced by implant, so can't rely on that. So I relied on the physical examination, and his ACL was functionally intact on examination. He was fully expecting me to recommend him a revision to a total, but I offered him something different. I offered him the add-in of a lateral uni. So I did this case today. So this X-ray is actually hot off the press. I think it's a very funny looking X-ray with those two unis in there. And I hope he'll be happy with it. He was very cautious about accepting my offer. He asked around, but ultimately decided to trust me. So hopefully he'll be as happy as I hope he'll be. So modes of failure in lateral unis. Most common cause of failure in lateral unis is medial OA progression, with the second most common reason for failure is aseptic loosening. Your mobile bearing implant, which is obviously completely avoided by using a fixed bearing implant. But literature says that using a fixed bearing implant on the lateral side has an increased rate of instability. Very important to consider is in doing a lateral uni is a joint line. If you lower it, you'll actually increase the load on the tibial component, and it'll loosen more quickly. If you raise the joint line, you'll increase the medial load, and you get an increased rate of medial OA progression. The outcome, similar to medial unis, and both are superior to the outcome in totals. But as with the medial unis, it comes at a price. Registry report worse outcome. But as you see with the medial uni, the groups that are from high volume, high experience centers actually show that survival rates are similar to that of totals. Obviously, Oxford makes a big deal of that and says that surgeon volume is one of the most important predictors of the survival of the medial uni. I don't think there's any reason to think that with a fixed bearing implant that's any different. As you can see, survival rates, but these obviously are from high volume, highly experienced surgeons, are similar to the medial uni and are excellent at 15 years. So for the lateral uni, in quick summary, same selection criteria as for medial unis. With the elderly and the less active, I tend to ignore the ACL status, and with the younger patients, I offer them a reconstruction, and if they refuse that, obviously they'll have a total. I aim for a slight undercorrection of the deformity. I really want them really want to leave the leg in valgus. There's no normal ligament balancing. You keep that in mind. You need to be very conservative in your tibial cut, or otherwise you'll end up with the joint line problems. And to avoid rotational errors, keep in mind those couple of surgical tips: the transpatellar sagittal cut, the resection of the lateral patellar facet, and the chamfer cuts and the chamfer cutting guide following the lateral edge of the lateral femoral condyle. And again, with unis, as I stated, if you're sparingly going to do them as with medial unis, maybe you shouldn't be doing them at all. I think at least 30 to 50% of your knees should be unis, and at least 10% of those should be lateral unis. To get enough exposure to the procedure to do it reliably and reproducible. So that's it for me. Thank you for your attention.
Fantastic. Well, again, thank you very much for that presentation. A tremendous amount of information covering really all aspects of the uni knee in comparison to obviously not only the medial and lateral approaches to it and against the H2O. So really fantastic. I just want to go into a few questions that we have. And you caught actually my first question there at the end of your presentation about your recommendations of the percentage that surgeons should be doing. I think that's an important thing to highlight, that if you only think you're going to do 5 to 10 of these a year, but that represents still 50% of your practice. So it's an interesting topic that we often get as surgeons are now considering, obviously, to go to use of a uni in their practice. So I guess if you can expand on it in two parts, which is, again, your belief on how much of this should be part of your practice for good results, and some tips that you have for surgeons that are going to be watching this for the first time and are ready to start going down the path of offering the uni knee to their patients.
So the first part of that question, I think that Oxford really nicely showed what percentage of your knees should be unis to get enough exposure to the procedure, and those 30 to 50%, that's from one of the Oxford papers. And again, I don't think there's any reason to think that those numbers are just for mobile bearing. They apply to fixed bearing equally. So I think you need to do at least 50 a year unis. I mean, 30 to 50 unis a year at least to get really good at it. So if you do 100 totals a year, I think you should aim for maybe do 30 unis. And the interesting thing is, and that's something you need to really force yourself to doing. If you look at literature where they retrospectively had surgeons look at X-rays to see what knee they might think is suited for a uni and what knee is suitable for a total, the uni believers actually say that in that retrospective study that 25% of the knees that they reviewed was suitable for a uni, where the non-believers only said that 12% of those knees were, those same X-rays were actually suitable for a uni. So you really need to force yourself to just stick with the selection criteria and not let subjective bias or what other people with their preference tell you. So you just need to go for the starting surgeon. You just need to go to your 65 to 70-year-old that has one of those x-rays that, I mean, all the x-rays I showed you had clear medial OA. There's bone on bone. The ACL is intact, judging from the lateral x-ray. You know, go for, start with one of those, and then try to expand on your indications like I showed you, only later on, after if you got a couple of under your belt. And also, if you really want to understand what's happening when you do the uni, you can use PSI, because then on the computer actually shows you what consequences your actions have. So upsizing, downsizing, shifting, increasing the tibial cut, etc., etc. Actually, it forces you to think about what's happening in the patient without actually doing the surgery. And then with the you don't necessarily need to use the PSI cutting guides, but you know, just stick them on the bone, see where the computer told you to do the cuts, then remove the PSI implants, and then have the and then do the surgery with the PSI, and then later on, you know, with the electrocautery, just mark where the computer tells you to do the cuts, and then, you know, set up the instruments, the normal instruments, and then see where you would end up if the computer didn't tell you what the where the cuts needed to go.
No, it's good. It leads me to two more, the next two questions, and one being age, which you discussed very significantly about age being a factor. But before I get to that, I want to stick with the instrumentation that you just brought up. One, can you explain your usage of PSI on the percentage are you using on your cases versus our conventional instrumentation with the standard instrumentation, if you will, with the Physica ZUK? And do you have a preference over the two? And again, back to the surgeon first starting, I think you alluded to the significance of using the PSI at least as a guide, but where do you go as far as your procedures now for using the computer-assisted aided instrumentation versus the standard instrumentation?
Well, when I started doing Physica ZUK, I was a huge Oxford user, and then I switched to the Physica ZUK. So I was used to the Oxford instrument, the conventional instruments. So when I started out, I used PSI. So I think for my first, 100 cases, I used PSI, and then when I got more confident with the procedure, I switched to the conventional instruments, and I'm happy to use those. The turnover time with having to do the MRI, waiting for the blocks to come in, and it doesn't make the surgery any quicker. For me, it doesn't make the surgery any quicker doing it with PSI. It doesn't make it any more reliable. I think my results with PSI or with non-PSI are similar to doing them with PSI. We have an extensive prompt system, so I can just ask the research department to have look my results up, and then they'll show you that they're similar with PSI and non-PSI. So I'm more than happy to abandon the PSI, but it helped me gaining an understanding of what I was doing during the surgery, having to look at the computer model pre-op.
No, I think it's a great tip. I really do. So let's go to the age. It was really interested to hear how you spoke to that. And obviously a lot of people and a lot of our surgeons viewing this, and in the community would think of the uni being geared towards the younger, more active patient, that they just have that unicompartmental disease going on. Therefore, they're the great candidate for it. But I guess I'm asking you to just expand a little bit to what you presented. And my question is, is it a factor of the younger patient does feel like they are too aggressive? You mentioned just being a manual laborer, but are they also trying to, do excessive rock climbing or doing ski jumping to some effect that you feel like maybe they're pushing the boundaries that they think they've now got rid of the pain and they're a younger active patient? How can you expand on that?
Well, obviously, what you say that holds true. That they're young, they're active, they want to get the most out of life, and their knee pain is gone. So even though you recommend them not to do any high impact activities, literature clearly shows that people with unis are involved in higher activity level sports than with totals. Um, maybe also psychologically, knowing that the uni can always be revised to a total. I mean, maybe that psychologically makes the patient less careful with their implant. I don't know. I'm just speculating. But you know, those registries show that with totals, the younger do just as bad. I mean, the under 55 do just as bad with a total as they do with a uni. They only do worse with a uni in terms of revision rate. So you just need to counsel your patient on that. I just tell them that if they're not careful, if they continue to be overweight, if they continue to do high impact loading, I can't guarantee them that their implant will last as long as it should. Also, again, Oxford has shown that with high volume, highly experienced surgeons, the survival rate for the cementless Oxford implant is just as high as with well-functioning TKRs at 10 years. So probably, as I showed with the medial uni numbers in one of those fixed bearing medial uni slides I showed you, survival in those high volume surgeon series is just as good as with or almost as good as with total. If you exclude disease progression, which really isn't the fault of the uni, that's just the downside of replacing only one compartment. If you take out those revisions, numbers pretty much reach in the hands of the highly experienced high volume surgeon, those numbers reach the levels of almost reach the level of a total. So again, can't stress enough the importance of doing high numbers of cases and being really experienced with the procedure. But obviously there's a patient factor as well.
Yeah. How often do you find when you do, or is it in your procedure, when you make your first incision, your initial incision, that you take a closer look at the other compartments, and do you plan for the chance that you may go total in that procedure, or do you feel like your protocol has you pretty well set that we're going uni and I'm 99.9% sure we're sticking with the uni?
I wouldn't say 99.9, but I'm 99% sure. Literally only probably once or twice every year I have to convert a uni to a total. There's always a total set waiting in the
wings. Yep.
Waiting, yeah, I know what you call it in English, but there's a total set, the total knee replacement set available for every uni I do, and only if I see a large central ulcer in the lateral femoral condyle, a bone-on-bone, so a central ulcer in the lateral femoral condyle that's all the way through to the subchondral bone, or there's a large central what do you call it? A ulcer, a large central ulcer in the lateral femoral condyle. Usually, and you miss those on the X-ray. If that's there, I abandon the procedure. But I ignore the patellofemoral joint status, and I only look at the presence of that central ulcer in the lateral femoral condyle. But that's there only once a year, maybe.
Good to know. Next questioning is around same-day surgery. What is it in your area for you, maybe personally, on obviously, as we, for us, United States, unfortunately, we do not have the Physica ZUK here at the present time. But as unis are done extensively here at a same-day ASC setting. How do you see that transitioning for your region, for the European region, and others, and maybe how it correlates, obviously, to what our current day scenario is in our world, and what COVID is possibly changing the way we, in fact, do procedures, both in the European section as well?
Well, do you consider same-day surgery discharge within 24 hours?
Yes.
Yeah. Well, most of our patients go home the next day at around midday, or maybe the latest 2-3 p.m. So we're pretty close to that 24-hour threshold. Same-day surgery in Holland is have the surgery on a Monday and go home on Monday at in the evening. For total hip replacement, ASI total hip replacement, there are some centers that do that. For the unis, I'd like to have them over one night, because sometimes the local infiltration anesthetic wears off a little bit quicker than you had hoped for, and then you have a very painful patient at night. So I'd rather have them in the clinic for that. Economically, it makes no sense to send them home the same day for now. So same-day surgery same-day discharge for me would be something to have a look at. Maybe in highly selected cases, have the first patient, the one that you do, because we start at 8:15, and usually the first case is done by 9 a.m.
Sure.
So why not have that patient go home at 7? That's something to look at. For now, we don't do that.
Yeah. Do you see the world and our situation accelerating that in the markets? Not only in your country but others, your surrounding neighborhood countries?
Sorry, I didn't hear that. The first part of the question, the audio was breaking up.
I apologize. With COVID-19, do you see the opportunity for countries to take a closer look at and growing in the same-day surgery type of setting, like you're speaking to, or getting patients out later in the evening?
Well, I maybe it'll cause a shift from doing elective orthopedic surgery even more from the general hospital to surgical centers, because obviously in general hospitals you have possibly COVID-19 infected patients in the hospital, whereas with day centers or surgical centers, you can just have them. You can have them screened at the gate, so to speak. That's what we do nowadays. We measure their temperature at the entrance. We ask them a couple of questions, and if there is a very low suspicion of infection, we're happy to have them come in within a general hospital with a busy ER and staff running and being in multiple areas of the hospital where there are infected patients. I mean, it's an excellent case of moving highly elective and plannable surgery even more out of the general hospital setting into the smaller surgical centers setting.
Yeah, trend, I think, universal. It's not for many countries, including here in the United States as well. Last area topic to speak to, and then ask Maurizio, as he'll have some final things to just wrap things up. Lateral unis, yeah. Obviously a much lower percentage, I assume, of your practice, the number of laterals you do to the medial. One first question is, what are your thoughts on a dedicated implant to just the lateral side in your hands, and obviously to your current system using our Physica ZUK?
Well, I'm happy to just use a right medial implant on the left lateral side, as is the current situation. I've used lateral domed Oxfords as well, and I found them highly difficult to balance, and I always had trouble with that, getting that domed biconvex insert in. I mean the domed tibia plateau and the biconvex mobile insert in, and I'm happy to use the fixed bearing right medial implant on the lateral side. So as is, I've got no reason to really want a dedicated implant for the lateral side. I'm happy with what I have.
Excellent. All right. So Maurizio, I'm going to give it to you here and hand you the mic, if you will. Just a couple final thoughts here, and some information you'd like to bring to the table.
Yeah, thanks. I want just to tell the story behind the consensus panel activity when we started. We started in 2019 in March, where Lima asked to 13 surgeons coming from Europe and Japan to deeply analyze the latest literature on patient selection criteria in unicompartmental knee arthroplasty. And obviously, Dr. Brinkman is one member of this panel. And at the end, the surgeons produced a sort of manuscript where they analyze their own topic, and Lima collect all these manuscripts in one volume, organized as a sort of consensus. The aim of this project was to create a useful tool, especially for surgeons that want to, for the first time, know more about the unicompartmental knee arthroplasty. People in this volume can read the opinion, tips and tricks of high experienced surgeons, high volume surgeons on the unicompartmental knee arthroplasty. The document, for those who are interested, is available on our website in limacorporate.com, and that can be easily downloaded. I want to once again thank Dr. Brinkman, the entire panel of surgeons that for the excellent work they did with us last year. I can even give the anticipation that we are working on the second edition of this volume. So looking forward to have some exciting news coming soon. That's all.
Fantastic. Dr. Brinkman, I'll just leave you your final words and your thoughts to that experience and any final comments as we wrap up our session.
Well, it was fun to have a whole day of discussion, just, hearing all those different opinions. People from all over Europe and Asia come together and discuss a common interest. That was a very, very interesting day for me, and I learned a lot, and I think it's a great document.
Excellent.
Thank you.
Well, gentlemen, it is time to wrap up our online education session for today on the Physica ZUK. Dr. Brinkman, thank you very much for a real thorough talk through, obviously, the use of our Physica ZUK in your hands, and great advice on the different approaches for surgeons to consider when utilizing this system and within their practice. So thank you, Maurizio. I thank you for joining us and being a part of this. And with that, we're going to say goodbye. Thank you all.
Thank you. Bye.
Bye.
Bye.